Good afternoon, everyone. Welcome to the Taster Lecture with the topic Built Environment for an Aging and Sustainable Society. This Taster Lecture is from the program MSc Healthcare Facilities offered here at the Bartlett School of Sustainable Construction. My name is Dorcas, and I have with me here Dr. Leah, who is the Program Director of the MSc Healthcare Facilities. So Dr. Leah will deliver the lecture, and then we'll move on to questions and answers. We encourage you to please ask your questions and please use the Q&A function at the bottom of the screen to ask them, and we'll go through them. Thank you again for joining us. Over to you, Dr. Leah.
Hello, everybody. Thank you for coming. Today, this is for you to have a kind of a preview of the MSc Healthcare Facilities with an actual lecture that takes place every year during the MSc. However, the MSc is not an online program. We do that in our amphitheater. We have one of our amphitheaters in the Here Is that is a Harvard-type amphitheater, an amazing space. Therefore, the online experience cannot match to it. However, because this is an online, you can watch that today from home. Hope you are sitting comfortably. You have a cup of tea or coffee, what you like. I have mine. And let's try to compensate with the fact that I cannot see you and we are not all of us together at Here Is. The lecture today is about older people and design for older people and why this should be done in relation to their physiology and perception. And I will bring some case studies from real world examples that demonstrate the need that we have to change the way we are doing things. So it's part of the last module of the MSc that focuses on the aging and long-term care and mental health, among the others, everything that is long-term and requires long-term healthcare buildings, which is mostly facilities for aging, care homes, facilities for psychiatric, facilities for autism. So but it's also something that is cross-cutting because aging is cross-cutting as a topic. Next slide, please. So, aging is not something that is unnatural. It's something that happens to all of us. And however, why we talk about aging so much is because suddenly it has become a big priority for policy. The reason is that we live in an aging society where more people will be older and living longer, and fewer people will be around to take care of them. And that's a result of demographics. And it will be with us. This creates a demographic problem that this generation has to face, and we need to give solutions. Because this is a big problem, how we are going to deal with a big inflow of older people in the healthcare sector and in our society. Yes, please don't change the slide yet. No, please keep the old slide, yes. Unfortunately, today I cannot manage the change of the slides. There is an issue with my computer, so I have some help with that. Apologies if there are any problems with the slides here. So, what has happened is that with all the technological and medical advancements, we managed to prolong the lifespan by 20 years. And but which is good news, and everybody's happy for that. The bad news is that only 2 of these years are years lived in health. Therefore, we have added 18 years of ill health in the burden of the healthcare service, in the burden of how do we provide healthcare and to the taxpayer also, but also to the people. And that's the biggest issue, because everybody wants to live longer, but then this having to add in their life 18 years of not being well is a big issue. So we need to find ways to treat people with respect, with dignity, in the best possible conditions, because you don't want the end of life to be something so difficult. Now, for that reason, and because, as I said, there is a big issue also regarding quality of life, but there is also a big issue for the burden to the health service, the burden to the social services, and governments, they don't know how they are going to fund and address this. They have put a lot of funding in order to provide solutions, to understand the problems, and then try to provide solutions for an aging society. The way that most policies and policymakers try to give the solution to where they are looking to find solutions is mostly in medical advancements and technological advancements. At some point, I was coordinator of the European Commission for the environment section of their big umbrella program for all the initiatives regarding aging. So the European Commission, at that time, the UK was part of it, and it is also part of the European research area. So even after Brexit participated in these initiatives, has the big umbrella initiatives to tackle their big problems. And these are the European Innovation Partnerships. And these partnerships, they bring stakeholders across the board. So from small SMEs to end users and the very, very big companies. There was an initiative on aging. I mean, it has been completed very recently. And that initiative involved many sections. So one was the, let's say, adherence to medication, another was about the silver economy, one was about the environment. So I was coordinating this initiative. And therefore, with this hat, I had a good understanding of where the taxpayers' money go in terms of funding for aging, and also what are the political priorities and how governments expect to solve these problems. And actually, in the European Commission, and the UK is not different because it participates in that scheme. And now it participates in the scheme that evolved from the EIP. The priority was on digital technologies and on pharmacological interventions and healthcare interventions. And they were expecting that with these two main vehicles, they can tackle the big problem of how we are going to accommodate people that live 18 years in bad health, more than what they used to. So this has been, and my understanding is that the big umbrella, the EIP on active and healthy aging, as it has been formed by the people who vote, the taxpayer and the politicians of Europe, and other big countries are not different in the approach, they are missing a very important element, and that element is the built environment. So I have done a lot of research in my life on psychiatric environments, on aging, but also I'm very active in policy making with different hats through different organizations that I combine under my main hat, which is being an associate professor and leader of the MSc Healthcare Facilities at UCL, and this I bring to the program. And with that inspiration, this lecture has been created. And and I will guide you to the 4 case studies that I think make the point that we need more than that for aging, more than technologies and pharmacological or other medical interventions, and we need to focus on the built environment as well. Next slide, please. My first case study involves a woman that I don't know. I've never met her, but she inspired me so much that it looks as if I know her. And that woman has had a very bad experience. One day she wanted to have a bath. She lives alone, like many of older people in Britain and across the world. She went into her bathtub, enjoyed her time in the bath, but then could not get out. She tried to get out for a prolonged period of time. Now I cannot interact with you as much as I would like. I would ask you in the class how long you think, and then students would guess. Here I cannot have that game with you, unfortunately. It's the structure of the webinar, but take a moment for you to think how much you think the woman spent in the bathtub. And now I will reveal the answer, and it was 4 days. And she has incredible survival skills because even though maybe she didn't thought she would die from hypothermia, she did the smart thing to pour hot water in the bathtub from now and then, so she didn't lose her body temperature, which is mostly how people die, for example, when they are immersed in cold water from hypothermia. So she survived for 4 days. She used to go to a cafe, and the waitress in that cafe every Wednesday noticed that she didn't come that day and searched for her. And they found her. But then that got me thinking. So how she would have solved her problem earlier? One element would be to design a better, to have a wearable, a device on her that would ring somebody that this woman is, for example, in the same spot for 4 days. The other technology that is used, and we are having a research project now on that, is cohabitating with a robot. And maybe the robot would check on her to see what happens to her. Another solution would be that the woman would be better connected, and we have research connecting the built environment with loneliness and aging, and that we know this is a big problem. So maybe in an environment designed differently that enable more co-presence of people and closer networks, perhaps she would have more people to look out for her. But also, these are all solutions. The prevention would be a better design of the bathtub, so that she doesn't need the wearable, she doesn't need the robot to check on her, even though the robot, of course, can be in the environment and check on her, but she wouldn't have to face this problem on the first place. And given that most of our bathtubs have the same design for almost a century or even more, and it shows that our built environment and our intimate spaces that haven't changed so much in design terms over the year are not ready for the new situation of many old people living predominantly alone in their homes. And it demonstrates that maybe we don't know how to design intimate spaces for actual people who actually use them at all times of their lives, when they are pregnant, when they are very young, when they have a problem in their like a mobility issue, or they are old and frail, or simply sick, like many of us during the course of our lives. But what I want you to keep from here is that there is a need to rethink our intimate spaces. Move, please, to the next slide. Yes, and I'm moving to two other people. One of them, maybe you are a bit too young to know, but it's a singer that I used to listen a lot when I was young. And it's Leonard Cohen, and the other person is my grandmother. And both of them had a very, very similar death. They woke up at night, went to the bathroom, had a fall in between, went back to bed, and they didn't survive many days from that. Next slide, please. I don't know the exact circumstances of Leonard Cohen's death, apart from what I told you, that it was a fall after waking up. I know the exact circumstances of my grandmother. My grandmother was not living alone. She was living with my grandfather. And she was not, here you can see her house in the very beautiful island of Chios in Greece. It was a multi-generational living program, something that is considered an excellent solution for all people, and something that policy in this country, in Europe, in other countries like Canada and the US is a topic that everybody is discussing right now. How we are creating new communities with old and young people living together, that each one can support the others. So very much, this is a project from the 80s in Greece. And this project was a public tender. It was a building that was designed with high standards, and they had a small house on their own. So theoretically, they lived on the same floor, both of them, but because both of them used to snore a lot, my grandmother was sleeping in one bedroom, and my grandfather was not using his bedroom, but was using the sofa in the living room downstairs, so they can snore as much as they like without waking each other. Next slide, please. On the left, on your screen, you see the bedroom, and then a corridor, the staircase leading downstairs, and the toilet. So she woke up, and you see also a red dot above the staircase on the wall next to the door of the toilet, and that is the switch for the light in the toilet. In the UK, most lights are in the room. In Europe, they cannot be in the bathroom. The switch can never be in the bathroom. Therefore, you need to switch on the lights before you enter the room. As I said, this is a public project with public specifications. An architect, maybe if they wanted to design something a little bit better, they probably would have moved the door of the bedroom a little bit for privacy, but probably the landing would have remained the same. What actually happened is that she tried, because she was a woman in her late 70s, and she was also taking some pill in order to help her to sleep, but even without the pill, she just woke up from a heavy sleep and tried to switch on the light to go to the toilet. But then she lost her concentration. Maybe she miscalculated the space, and she fell on the steps instead of going into the bathroom. My grandfather was downstairs. He immediately woke up, called an ambulance. The ambulance came immediately, but unfortunately, my grandmother did not survive the fall a few days later from the bruises. Now, if she had a wearable, because this is where taxpayers' money go, nothing would be different, because she would still have fallen, and she would still have an ambulance as quick as my grandfather calling an ambulance. It's a small island. It's not that there is a big queue for ambulances. And as I said, small place, the ambulance came pretty much as fast as they could not taking a long time. So any intervention happened as fast as possible, and she was in great hands, but apparently the injuries were a lot. And actually, she's not the exception, because falls is the biggest killer in Europe for old people. And most people that have a fall at that age, most of the time, they will die within a year. So fall prevention is a big topic. Intervention after falls is also a very big topic for taxpayers and Europe. But here I want to tell you that with the built environment, we can prevent a fall if we design better built environments. Next slide, please. So the fall would be presented if instead of the corridor in the left, we would have a corridor like that on the right. But most people, most architects that I know, maybe including myself, would not have designed a corridor like that, because it would squeeze the space that we have available for the staircase. It would not create a better configuration. It doesn't look as neat as the space on the left. And as I said, this is a public project with all the requirements, and it is and also a public project means there was a tender with a very capable firm of architects being selected. But it also means that we are not aware when we design private spaces like homes, residence, of the issues old people face, and we don't exactly know how to design for old age. And then I will move to my next case study, please. Next slide, please. And that is an excellent example of a very, very well discussed healthcare facility, which is the Dementia Village in the Netherlands, Hoogvliet. This is a very much discussed project that is considered one of the best places, most innovative places for caring for dementia, to the point that it's replicated in many countries around the world as we speak, including the UK. This is the first one. And essentially, it used to be a care home, like a tower care home, that they replaced in the same land with smaller facilities, like several smaller houses and some communal areas, like a theater, a communal supermarket, etc., to make it more friendly for dementia, for people with dementia, and more natural for them to be in an environment that reminds them a Dutch village rather than a care home. Can we please move to the next slide? It has been designed with a lot of care. Here we see the main entrance from the outside of the village. We see the music room, the communal area between the restaurant and other amenities, the supermarket, art that reminds people why they are there, what they can do in that area. Like this is the small alley next to the supermarket. It has a restaurant for families and people, residents, to meet and eat together. And they take care of every detail. For example, if you want to shop in the supermarket, you can go there, buy as many things as you like. You don't buy, you don't pay. You just, a person maybe with their carer or alone, they can grab a trolley, put things in their cart. It doesn't matter if they only need one pack of pasta and they pack like the whole section of pasta in their basket. Their carer will then return the rest of the pasta safely. But the person at the till knows that this person can bring whatever to the till. They will pretend, they calculate, they will pretend there is a transaction. The person will go back happy that they did their shopping. The carer will use in the kitchen whatever they find useful, and then simply they will return everything else. So there is a management that happens many times, like in facilities for dementia, it happens in hospitality for dementia, and it shows that these people in that village, they really know how to treat people with dementia, advanced dementia, like the residents of the village. However, when I visited the village, I noticed that next to the restaurant, there was, next slide, please. the toilet of the communal area, that it is there for patients and relatives to use alike. And like the rest of the village looks exactly like a Dutch home and a Dutch supermarket and a Dutch village, this looks exactly like a Dutch home toilet. Like 99% of the homes in the Netherlands, that will be their toilet. Normally, they have a separate space to wash the hands and they have a small closet only for the toilet. And very, very similar to what you see here. Very, very similar color scheme. Very typical Dutch home, these tiles with a white tile, with a toilet bowl. Maybe the only thing that you wouldn't see in a Dutch home, it would be the disinfectant. Also, the size is not a typical public space design or hotel design. It is the typical Dutch home dimensions, which is very, very, very small. Incredible if you think that Dutch people are the tallest people in the world. But so this is a tiny space that looks familiar, especially if you are from the Netherlands. But if you have dementia, it might be illegible. And the reason is because as we age, dementia causes perceptual difference for the person. The person cannot understand things as easily in the environment, but also causes physiological issues. And part of the physiological issues is that you see everything a little bit more yellow, a little bit more vague. So the vision deteriorates significantly. And looking at a room like that, everything is white from the lens of a person with dementia. The person would not be able to tell where is the floor, where is the wall, where is the toilet paper, where is the toilet. And they will be stuck on their own because a carer does not fit in that space for the first time in the dementia village. And if they are disoriented, the dementia causes that, they would be stuck in a tiny place on their own without having the ability to necessarily understand how the space is used. And also because they are old people, probably they have multimorbidities that they might require some help with them sitting or lifting themselves. And this specific design does not enable to have any aid to sit or lift yourself. So it has a lot of issues, both for the perception of the patient and for the physiological situation of the patient. Therefore, it's not a design that is suitable for an old person in particular, especially for dementia for many, many reasons, but for any old person. Yet we find it in the most celebrated, discussed healthcare projects that I'm aware in the recent years. CNN has written how wonderful the Dementia Village is, BBC has written, Bloomberg, it is a widely discussed facility. Yet, from the design of this space, that I can understand the intentions, as I explained, we can tell that it is not a place well designed for dementia. And probably, as I said, we cannot design, we are not 100% sure how to design intimate spaces and how to design public spaces. There is a question mark on how we design, from this example, on how we design healthcare facilities for old people. And then I will move to the next and last case study, please. Next slide, please. And this is a car park. This is a car park that actually it was presented in an architectural presentation when I visited some students in a Master's of Architecture. And there was a very, very famous architect of one of the very, very big architectural practices. I would say, think one of the biggest 5 that you can think in your mind, the most celebrated architects, and it is one of them, I can guarantee that. Maybe in the top 3 as well. And they were explaining their projects, and I saw this car park, and I thought that this place is not suitable for people with autism, is not suitable for people with dementia, is not suitable for people who are old and for people who have visual issues. Because there's so strong visual lines that some people might not cross, especially if they perceive them as change of level. And maybe or if they do cross them, they would perceive them as changes of level. Therefore, they would adjust their movement, and that might create the possibility of a fall. And I already explained how dangerous are falls for old people. When I mentioned that to the architects, the response was, but we don't design places for aging, although this is a public car park, and I assume they don't have an age restriction in order to get in there. And they say, predominantly we design like these very fancy workspaces, like in the city of London or Dubai, Qatar, or we design airports. And next slide, please. That was very strange, because one of the priorities of a lot of countries right now is silver economy, silver traveling, and how we will facilitate movement of all people, either for recreation or for fall prevention or for medical tourism. And actually a lot of people travel. And next slide, please. And we know from research that when people travel and they, especially when they are jet lagged, and you don't need to be old for that, any person can have that problem. The normal orientation devices that exist, like the digital ones that we normally rely on everyday lives, like Google Maps, etc., they are not good enough when you are jet lagged. And you need more visual cues and visual help and built environment interventions in order to get there. So, like traditional ways of wayfinding. So this example demonstrates to me that I will go back, we have a difficulty understanding the issues with intimate, private, and healthcare spaces. We can say from that example that we need to rethink how to design public spaces as well. So it's the whole spectrum of the built environment that needs to change. Next slide, please. However, in most architectural schools, in most schools of the built environment, and our own is not an exception, young architects or aspiring architects, they don't learn how to design for aging. They don't learn how to design for old people. They learn wonderful things like, next slide, please. This is a picture from the Bartlett exhibition. Amazing things what these students do, but still, aging and healthcare is not perceived so much as the big issue that it actually is. And next slide, please. And there are only very, very, very few indications that I might be aware, and not any recent ones actually, that, for example, there were efforts like here where a colleague tried to, and that colleague also participates in the MSc, tried to demonstrate to architectural students how, for example, if they change their perception by putting a camera, like blocking their vision, and instead of seen through their eyes, seen from a camera in a different part of the body, ask the students to move and perform simple tasks, and people were not, and because their perception of the body changed, people could not do the tasks as normally. But this is not something that happens if somebody places a camera on you, and if somebody, it happens if you are old, it happens if you are ill, because both your perception and your physiology are compromised. You cannot move as you used to move. You might not be able to function or see things the way you saw, like a person with cataract, a person with a visual impairment. They cannot navigate in the environment, but also a person with mobility issues, but also a person under medication. And we know that old age comes with a lot of medication. So, next slide, please. Then I remember what I have been, what I learned when I was a student of architecture many years ago. And we learned about Frank Lloyd Wright and the famous book, Letters to a Young Architect. And is it Frank Lloyd Wright? I might. Anyway, so the famous book, Letters to a Young Architect, correct me if I'm wrong. And this is in that book, because it's a book that is very important. It says, doctors bury their victims underground, and architects bury their victims under ivy. What does it? How does this translate? That the doctor has a big social responsibility. If you make a mistake, the person might die. But as an architect, if you don't design a good building, somebody will cover your building with some green. And so where is your social responsibility? Probably you don't like that at all, because your work will not be visible, or at least as you intended, but you don't do much harm. At least you make a building more sustainable. So where is the social responsibility for architecture in that paradigm? Actually, not much. But what about the medics? What do they learn? Next slide, please. Every doctor, every clinician, they have to learn the Hippocratic Oath. The Hippocratic Oath starts with the phrase, first, do no harm, which means you need to know what you are doing in case by your intervention you harm somebody. So not all interventions are good. So you need to have a lot of knowledge, and the knowledge of your limitations, the knowledge of the possibility of causing a problem to somebody. So that's the first phrase, do no harm. And the second phrase is, and then try to do good. So once you establish that you know what you are doing, that you are not harming anybody, that your bathroom or car park or your toilet is not or your staircase is not going to damage any person, then try to do good. So you cannot do harm unintentionally, and you cannot do harm intentionally. And your actions have to be towards a greater good. And you need to swear that in order to become a doctor. And I'm thinking that architecture would benefit a lot from this paradigm. I don't believe that people go to the built environment to do harm, quite the opposite. The built environment has a huge power for societal change, but the first part is missing, where people are 100% aware that the built environment intervention might not necessarily cause good, or might not, and might be harmful. So this is what we try to do in the MSc. We try to learn how we design for aging, how we design for old people, how we design for people who are sick, how we design hospitals, how we design multi-generational communities. But the paradigm needs to be from the first, do no harm, and try to do good. And next slide, please. That's more or less what I have to tell you today. These are my details if you want to ask me or come back to me, ask information about the MSc, but more or less it's that. So thank you for your attendance, and let's see if we have any questions, etc.
Okay. Thank you very much for that, Dr. Leah. I found it really interesting. It was insightful. It was thought-provoking. So now we'll be taking questions, and Dr. Leah will be answering. And we have like about 12 more minutes. So please do send in your questions using the Q&A function at the bottom of the screen. Or if you would like to speak, you can use the raise your hand function, and then I'll unmute your mic. So Dr. Leah, I have one question here. So would you say that every architect and built environment professional should know, even if it's a little bit, about, building sustainably for the aged? Or would it be more of a case that more medical architects should be involved in construction projects?
I think both. Actually, I believe that this is a great degree for everybody who wants to advance their architectural career and then go back and design whatever they like. But it is incredibly important that people study like about healthcare environment specifically. We don't have enough people for the need. I see how our graduates, how they find jobs very easily, the ones that are young people and either in architectural offices, mostly designing complex architectural projects, or a lot of them go back either where, we have two groups of students in the MSc. One is like people with very advanced careers, either in architecture or other built environment industries and the NHS, the health sector, or ministries of health from their countries, etc. The European Investment Bank, for example, the people who evaluate healthcare facilities, or young people that study for the first, before their first job. And I noticed that a lot of our graduates, they go, especially from that second group, a lot of them, they continue with a career in the NHS. So there is a lot of need in the health sector. There is a lot of need in healthcare planning companies. And there is a lot of need in architectural firms, like healthcare architecture firms, for young talent. And there are no graduates. This is the only program in the world. We take very few people because we cannot have a capacity to have like a huge amphitheater, because we need to take people to hospitals, and a hospital will never accept you if you have 50 or 100 students. So the program is always small, and we have few graduates so that we can be able to take students to see hospitals. But therefore, there is no other program in the world to study something similar. So that's the only program who produces people specialized in that discipline. And therefore, there is a big need in the industry. There is a big need in reality. And I see that our graduates, they end up having all sorts of careers, either in policy, like the European Investment Bank, for example, where they evaluate projects, or companies like big investment firms, but also a lot of people in the NHS and a lot of people in the architectural industry reshaping it. So it's buildings become better for people who either they are on medication or they are ill, or these are complex healthcare facilities. Yes.
All right. Thank you very much. So if we do not have any more questions, I think we'll wrap it up here. So thank you very much, Dr. Leah, and everyone for participating. I have added the link to the prospectus in the chat, so please do take a look if you're interested in the MSc Healthcare Facilities. So yes, we have now come to the end of this TASTER lecture. Thank you very much. We hope you found this lecture informative and insightful. So yeah, have a lovely rest of your day. Dr. Leah, any words?
Yes, so thank you very much for being here today. It was a very successful webinar with a lot of people I could see as participants. If you want to come back to me and discuss with me either about the program or anything else relevant to what we discussed today, please, I'm available. Something that I want to mention is that this is a very interesting program for people to study. It is not only a unique program, it has also a unique delivery mode. So if any of you are professionals and you don't want to leave your job to study that program, this is a program tailored for you. So we have very, very, very intense weeks, like 1 week of very intense study. then a gap before where you need to work individually before the next module starts, which is also very intense, 1 week. But if we have people who are, for example, students who are working, a lot of our students are doctors. They are not only architects, and they cannot leave the hospital, especially at these difficult times. They might do the program part-time and come only to study, for example, few modules per year. They only come, let's say, 1 week to study every module. They can take the MSc up to 5 years. And this is especially important for professionals. And this is also, and that's why we have a lot of professionals studying together with a lot of young people. And there is an incredible cross-pollination when the two happen. So if you also want to start to ask questions about the mode of study, etc., and you have specific questions that are very specific for that program, please don't hesitate to contact me. So thank you very much.
Thank you very much. Bye, everyone.
Bye.